Okay, so we are going to take a look at cerebral dysfunction. So grab a beverage, your favorite pen, your printed PowerPoint, and probably a snack. This might be a little long one, and we'll get started. So when we're looking at cerebral dysfunction, one of the main causes has to do with increased intracranial pressure. And if you think about it, inside the skull, there's not a lot of space to move around. So we have the contents of the skull, which is the brain, which makes up about 80% of it, the cerebral spinal fluid, which makes up 10%, and the other 10% is made up of blood. So if any of those things increase in size, we're going to have an increase in intracranial pressure. So we really need to remain constant with that 80%, 10%, 10%. And if we don't, we're going to have issues. And you can kind of think about this as the opposite, but remember back to OB when we talked about one of the side effects of an epidural is a spinal headache. That's because some of that cerebral spinal fluid is flowing out, and so we're losing volume there. So we have a decreased intracranial pressure with the headache after an epidural. And so now we're going to look at increased intracranial pressure. So here's a great picture. This is a coronal section showing the meningeal layers of the brain. You can see all of the various structures and layers and potentials for injury. So what's the best way to assess the function of the brain, and specifically the intracranial pressure? It's going to be level of consciousness. Now, we all know we're going to go ask our patients their level of consciousness on a regular basis, right? We do LOC, alert and oriented ×3 assessments on a semi-regular basis, and they're part of every head to toe. So that's something we're going to look at for children as well. Now, we might need to change what we ask just a little bit, and we might need to utilize the parents as well. Children are not going to be very responsive in unfamiliar areas, and they're not going to really want to respond to unfamiliar people either. So we're going to have to elicit the help of those caregivers who the child is familiar with. They also might not be able to articulate the place and the time. So we need to think about how we can ascertain whether they have a decreased level of consciousness. And again, a lot of that is going to have to do with the caregiver. And then in addition, we can look at their activity. Specifically, we want to look at their response to their environment and whether they're having a response that's different from what they have previously had. And that's going to be the best way to assess the child's level of consciousness if they're unable to articulate and answer the questions that we're asking them. So we're going to go from having full consciousness to being confused, disoriented, and then lethargic. So in the lethargic state, we're looking at a coma, and we have a couple different ways that we can assess comas in different scales. The Glasgow Coma Scale is the most common, and you should familiarize yourself with the scale and how to rate children on the scale. And this gives providers and the healthcare team a standardized language to communicate about what's going on with that child and where they are in the coma assessment. When we're looking at the various aspects of it, we're looking at whether their eye opening, their verbal response, and their motor response to rate them on the Glasgow Coma Scale. When we're looking at brain death, we're looking at the complete cessation of brain function. And we're going to do this by looking at flow studies. So we don't only look at the electrical activity, but also of the blood flow and the cerebrospinal fluid that's occurring in the brain. Brain death is irreversible. So this is how we're going to assess for that Glasgow Coma scale. So again, take a look at this in your book and become familiar with it. So when we're looking at assessing increased intracranial pressure, we're going to utilize our level of consciousness. We're going to take a look at the pupils. We want to know if they're equal and reactive, and we're going to take a look at vital signs as well. So how frequent we do the vital signs is going to depend on the severity of the condition. So we could be doing vital signs every 15 minutes, or we could be doing vital signs every 2 hours. And that's just going to be determined, again, by the severity of the condition. There's a great box in your book 46.1, which gives you the clinical manifestations of increased intracranial pressure in infants, because these little ones are not going to be able to obviously communicate where they are, what time it is, what day it is, any of those types of level of consciousness questions that we would typically ask. So take a look at that box. It's the slide here has a few of them listed. So irritability with poor feeding, a really high-pitched cry is not normal. The fontanelles, so their fontanelles, remember those are soft spots. So if they're tense or bulging, there's increased intracranial pressure, because that's actually a spot where it can expand just a little bit. And then we might see some separation in the sutures. And those of you who have gotten to feel baby's head, you know, sometimes they're overlapping at birth, and sometimes there's a little bit of separation. But if you have the separation of the sutures along with the bulging fontanelles, that's going to be an indication of intracranial pressure. And then we're going to look at the eyes and the veins on the scalp as well. Luckily, most of these little ones are bold, so we can see those veins pretty well. In children, increased intracranial pressure is going to manifest a little bit different. We're going to see they're going to report a headache. They're going to have forceful vomiting, and it's vomiting. It doesn't really stop. It's very forceful consistently. Seizure activity, drowsiness with lethargy. They're not going to want to move around a lot, and they're going to have a difficult time following simple commands. So there's going to appear to be some regression going on for that child. So some late signs of increasing intracranial pressure would be more of the physiological signs. So bradycardia, decreased motor response to different commands, decreased sensory response to painful stimuli when we see those pupils not reacting or pupil sizes different, and then some posturing. And we're going to look at those a little bit closer here. So when we're looking at level of consciousness, we have a couple different ways that we can, it says continued. I'm a little bit confused because there wasn't a slide before that, but that's okay. Just a mistake. So when we're looking at levels of consciousness, we have different levels of consciousness. So they can be aroused with some stimulation, only the vigorous stimulation, no motor response whatsoever, no verbal response, even to noxious stimuli. That's going to be your coma. And then the persistent vegetative state, where we have a permanent loss of the cerebral function. Now, a persistent function of the cerebral cortex. So persistent vegetative state is going to be a little bit different than brain death, because in brain death, you don't have the function of any aspect of the brain. So the brainstem and the cerebellum are gone as well, whereas the persistent vegetative state, it's primarily the cerebral cortex. So the brainstem functions still work, so breathing is still intact, and a lot of the normal bodily functions will still work in the persistent vegetative state. So when we're doing a neurological examination on children, we're going to take a look first at their vital signs. So we might see an increase in temperature if we have increasing intracranial pressure. We might see a rapid pulse. We could see a slowing pulse. We could see a bounding pulse or a febrile pulse. So it could be all over the place. Pretty much what we're looking for is inconsistency from one set of vital signs to another, or even while you're actually taking the pulse, there's going to be inconsistencies there. And with the temperature, it's more likely the temperature is going to be increased. For the skin, what we want to look for is any site of injury. So where might the impact have happened, and what do we see? And can we determine from the injury the extent of what could possibly be going on inside that little one's head? And for eyes, we want to take a look at the pupils in addition to the child's ability to move the eyes, because those are all controlled by those cranial nerves. So if there's cranial nerve damage, then we're going to have issues with the eyes themselves. Motor function, we're going to watch their spontaneous activities, specifically their gait, and see if it's steady and even. And if they're not able to walk, then we'll look at reflexes. Reflexes are really great with infants. They are not the best and not the best thing to assess in a child who can actually speak and talk and walk. You're going to obtain more information from them doing those activities. However, reflexes are great for infants who are not able to communicate effectively or walk. We're going to look at their moral reflex, their tonic neck reflex, their withdrawal reflexes, because those should all be intact. And we might see a child who has a neurological assault acting in a hyperactive manner. And if that's not normal for the child, then that's definitely a concerning observation. They might have tremors, be twitching, be combative, and be negative, have negativism. So those are all things that we want to look out for. And as for posturing, when we have a neurological assault, we might see primitive postural reflexes come into play. So here's a variety of different issues that the eyes might have. You can see pinpoint pupils, unequal pupils, dilated pupils, the eyelids having difficulty, the eye itself lagging. So just the pupils are going to be a key, and the eyes themselves are going to be a key assessment in the neurological examination. I talked about posturing. So here are those postures. In A, you can see flexion, and this is going to be an indication that the cerebral cortex is involved. So it's usually lesions, or the cerebral cortex, or it could also be lesions in the cortical spinal tract above the brainstem. So this is the cerebral cortex or the cortical spinal tract above the brainstem is what you're looking at for posturing for A, which is flexion. In B, we're looking at extension, and that's going to be midbrain or brainstem injuries. So how are we going to care for these little ones who are unconscious? And I cannot stress enough the importance of the nurse when it comes to caring for the unconscious child, because the most minute, small little detail that you pick up could save this child's life, because it could just be something really small that's going to change. That's going to be an indication that there's a buildup of intracranial pressure. So your observation skills will absolutely make a difference for these little ones, and just staying diligent and vigilant for them is of utmost importance. When we have an emergent situation, so an immediate acute need, we're going to establish an airway, because even though they're unconscious, we still need them breathing, right? We still need oxygen circulating throughout their bodies. So we're going to ensure we have circulation and airway. So establishing an airway and ensuring adequate oxygenation is key. The next thing we want to do is decrease the intracranial pressure. However, that might be done. There's a variety of different ways, and we'll talk about those a little bit later, but we want to quickly reduce the intracranial pressure, and a quick way that we can do that in minimally invasive is positioning. So having the head of the bed about 30 degrees is going to be the best position for the decrease of intracranial pressure. And then we're going to want to treat any shock that occurs and make sure that the patient has adequate circulation. We talked briefly about respiratory management. So again, the airway is going to be key. We want to make sure that this child is not without oxygen for more than 4 minutes, and much less than that if possible. CO2 is going to increase the cerebral blood flow. So if we have a child who is deprived of oxygen and has an increase in CO2, we're going to then have more blood flow to the brain, which is going to increase our intracranial pressure, which is not what we want, right? So we also are at an increased risk of aspiration of any secretions that might be present, just because their gag and cough reflexes are probably going to be minimal at this point in time. So when we're monitoring intracranial pressure, when to monitor intracranial pressure is going to be if we have a Glasgow Coma scale of less than 8, if we have a traumatic brain injury with an abnormal CT scan, if we have any sort of deteriorating neurological condition, and if we have just anything that we think clinically requires more monitoring. So we're going to monitor, again, just like the neurological assessment, it's going to be every 15 minutes to every 2 hours that we are assessing the way that we're monitoring the intracranial pressure. It's typically done via catheters that are placed in the ventricle. There can be a catheter placed in the epidural space, but it's typically a catheter placed in the ventricle in the brain. That's going to tell us what the pressure is. And so we'll have it hooked up to a machine that will give us constant information. However, from a charting perspective, it's going to be every 15 minutes to every 2 hours, again, depending on the condition of the patient. So I mentioned we talk about what to do for this increased intracranial pressure. So positioning, again, is very important. We want to make sure that the head is positioned in a way that's not going to compress those neck veins so that we can get adequate blood flow in and out of the brain. We want to provide an alternating pressure mattress. We're not going to be turning these patients ourselves. So there's mattresses that are great because what it does is, if here's your mattress, it'll pump one part up and kind of lower part so that there's the pressure differentials. The pressure is placed in different spots on the patient's body so that we don't get any pressure ulcers, because turning the patient is going to potentially increase that intracranial pressure. So we want to avoid that. And again, we want that head of bed at about 30 degrees that's going to be the optimal position to decrease the intracranial pressure. Activities that might increase ICP would be anything that's going to elicit pain or stress. So we're going to avoid those as much as possible. Now, we are in the hospital setting and we're trying to treat this patient. So there might be instances where it's necessary, but we're going to do everything we can to avoid environmental stimuli, environmental noise, painful stimuli, and things of that nature. for environmental stimuli, what you can do as the nurse is cluster your care. So instead of going in every 5 minutes to try to achieve all of your assessments and care goals and medication administration and cares for the patient, you want to cluster your care. And typically it's good to cluster your care around the medication times. Since those have standard times, you can make sure that you're going in and doing your, say, your Foley care at the time that you're administering your medication, as opposed to doing your Foley care, going to the Pyxis, getting the medication, coming back, and giving the medication to the patient. So clustering the care is going to really help to reduce that environmental noise to help keep that intracranial pressure down. Suctioning is a big no-no for ICP patients. So unless it's the only way to get rid of the secretions and they're having major, not necessarily major, but they're having recurrent respiratory issues, we are not going to be suctioning these patients because that will increase their intracranial pressure. So a good alternative is going to be vibration. And those beds that do this business of changing the pressure on the mattress, they also vibrate to help to eliminate the need for suctioning, help to eliminate the secretions altogether. How about hydration for our increased intracranial pressure patients? So we're going to want to keep a really close eye on these patients' hydration, because if we overhydrate them, they're going to have increased volume in their circulatory system, which is going to increase the volume in their head even more. So we're going to avoid overhydration and just keep a close look on, or a close eye on their eyes and nose to ensure that we are not giving them too much fluid. This overhydration will prevent cerebral edema. And to assess to make sure that we're adequately hydrating them, we're going to assess their skin turgor and their mucous membranes. So, the skin turgor, we're going to make sure that they're hydrated by tenting their skin, and then just making sure that they continually have moist mucous membranes. And we're just going to watch the fluids, because the fluid needs for each individual child is going to be different, especially based on their size, based on what caused their intracranial pressure increase, all sorts of different things. So when we have a head injury and we have a variety of different CNS things going on, we end up with some altered pituitary secretion as well. And so we could potentially end up in SIADH, which is going to cause overhydration and an increase in the intracranial pressure. So what happens with SIADH, if you remember to your med-surg class, is that we end up with decreased urinary output, but we were adequately hydrated and end up having fluid overload, essentially. So this is going to cause an increase in the intracranial pressure. The other aspect is the diabetes insipidus, the DI. So with this one, it's going to be the opposite. We're going to have a drastic increase in urinary output, but it's not due to the amount of fluids that's being taken in. It's going to be just the body getting rid of fluids. So the child will be at risk of dehydration. So both are going to cause significant electrolyte imbalances that we're going to want to treat and be conscientious of the fluids that the patient is receiving. So one of the things that we're going to look at treatment is from a medication perspective. We can treat the infection if it's an infection process. We're going to utilize antibiotics. Corticosteroids are really good for inflammation and edema. Sedatives or antiepileptics are going to be good for the seizure patients. Sedatives are also going to help with the combative patients and the patients that are agitated. So the kids who are having a difficult time and are awake, then we might want to sedate them. The sedation and amnesic anxiolytics are going to do the same thing. So we're going to administer those with a paralytic to decrease the intracranial pressure. The barbiturates are, like it says here, they're controversial. It does put the patient into a deep coma, and it's going to be the last result because the patient might not come out of the deep coma. So we want to make sure that we've exhausted everything else before we go to that type of treatment. And when we're looking at medications, we really want to ask the question of what is the cause of the intracranial pressure increase? Is it the infection? Is it the inflammation? Is it that the patient's having seizures? Are we not able to control it because the patient is combative? So really looking at the cause is going to help us make a decision as to the treatment. Now, obviously, the prescriber, the provider is the one making the prescriptions, however, or giving the orders, the med orders. However, you might have a variety of different medication orders that you have available to you on a PRN basis. So then you would have to make that decision. So we obviously want to keep pain down because the pain is going to increase the intracranial pressure. But how do we tell if a patient who is in a coma is in pain? So we're going to have to look really closely. And again, these neurological patients require astute assessment and observation. So we're going to look a lot at their vital signs and just how the patient is acting. So are they becoming more agitated and more rigid? Is their heart rate up? Is their blood pressure up? Is their respiratory rate up? So we're going to look at all of the physiological signs that we can, in addition to just having an understanding of what potentially could be causing this patient pain. And so we were able to put that all together and come up with a pretty good idea of whether or not the patient is experiencing pain. If they are, we're going to look at a couple different things. So opioids are controversial for a couple different reasons, but that's kind of going to be a last resort. So acetaminophen and codeine is going to be one of the first things that we go to because it adequately controls the pain and is safe for these patients. It's also going to help keep temperature regulation and it's going to take care of the majority of pain that's being experienced. We also want to provide comfort measures and, like we talked earlier, keep the environment quiet and dimly lit. So when we're caring for these increased intracranial pressure patients, we need to ensure their thermoregulation. So typically they're in a hyperthermic state. So again, keeping the blankets to a minimum, administering any antipyretics that are ordered, and ensuring that the patient's room is at a comfortable temperature. We don't want to do ice baths and things like that, but just the minimal intervention. So a sheet instead of a blanket and temperature of the room and the antipyretics. As for elimination, so these patients are not going to be getting up to go to the bathroom. They're most likely in a comatose state. So a urinary catheter is going to be placed, which we really need to be careful with risks for infection. So doing the catheter care is going to be incredibly important. For the bowels, most bowel function will stay intact, and all it will require is a little bit of a stool softener. Sometimes a laxative or enema is required, but a stool softener typically takes care of things. Hygiene care. So we talked in the cardiac lecture about or we will talk in the cardiac lecture, depending on the order, about how much bacteria is in the mouth and that bacteria being released. So hygiene care is going to be incredibly important. We're going to want to provide it twice a day, and making sure that the skin is clean. We're going to do mouth hygiene. We're going to brush their teeth twice a day. And the other aspect we really want to keep clean for them is their eyes. So making sure to wipe their eyes, making sure that they're able to close. Some states the eyes are open a little bit, they're going to dry out. So taking good care of the patient's eyes is going to be very important as well. So position, we talked about wanting to position the patient at the best position to decrease the intracranial pressure. We want to make sure to avoid aspiration or the potential for aspiration. And then make sure there's no pressure on any of the bony prominences. So the coccyx, the elbows, the shoulder blades, the heels, those are all going to be common spots for those pressure sores. So we want to make sure that we're providing the adequate equipment to avoid that when possible. Stimulation is going to be good in certain ways. So we want to provide simple tactile stimulation. Auditory stimulation is going to be really important. The hearing is the first to come, it's the last to go and the first to come back. So we want to talk to these children as if they can hear us, because they probably can. So we want to give them as much information as we would if they were awake, and provide that continual stimulation, because the brain will still work and function and process that information. And then when they regain consciousness again, the auditory is that first thing to come back. They're going to have they'll first orient to person, then to place, then to time. Usually it takes a little bit of time for their personality to come back, especially if they have to remain in the ICU. So they're usually scared and anxious in the ICU. Once they transfer out of the ICU, you see little bits of their personality coming back. From a familial support perspective, we really want to make sure that the patient's family has the resources they need. Social work is going to be involved. This is probably due to an accident. They're probably going to feel guilty. They're going to be scared of what's going to happen. Is this child going to have lasting effects of this? They might have some hostility, anxiety. They're not going to know what to expect. So keeping that in mind as we communicate with the family and provide education is going to help to empathize with the family and what they're going through. Like I said, the most common cause of intracranial pressure, an increase in intracranial pressure, is cerebral trauma. So we have falls, motor vehicle accidents, and bicycle or sports-related injuries being the top of our list there. So when we have a head injury, there's a couple different ways that the brain can be injured. So we could have acceleration injuries, or deceleration injuries. And keep in mind that child's head is big compared to their body, especially compared to an adult. So the head is going to be it's going to take the brunt of a lot of things, and their necks are not developed. Their musculature is just not as developed to stop it from moving rapidly. So when we talk about a primary head injury, we're talking about things that occur during the time of the trauma. So you can see the list of primary head injuries here. And you can see this picture here. So we have So your primary head injury would be with A and B, and then you can see that the brain would potentially be moving. We could have injuries along the lines of C and D, where we have some detachment injuries there. So when we refer to a concussion, we're referring to an alteration of neurological or cognitive function with or without loss of consciousness. And this is a result of head trauma. It is transient and reversible when it happens once. We've all heard lots of research recently about the effects of multiple concussions, but one concussion is transient and reversible. The child typically has some amnesia and confusion following the actual injury. When we talk about a contusion and a laceration, we're talking about it in terms of tissue. So you can see we have bruising, we can have tearing. Croup is bruising at the point of impact. So if you hit here and the brain smacks, we're going to have bruising on this side, but then it's going to come and hit in the back of the head too. So like we looked at this picture back here, we could have multiple sites of injury, even though we're just hitting, for instance, this looks like a potential windshield hit. So we could not, our site of injury isn't going to be localized to just where the point of impact is. And we have a variety of different fractures as well. Those little infants are going to be less susceptible to skull fractures because their skull isn't solid yet, so it's able to move and be manipulated a little bit more than our skulls, which are solid and are not going to move because our sutures have fused. When we are looking at the types of skull fractures, we're talking about linear fractures, which are the most common kinds of fractures. It's a single line and it doesn't cross the suture lines. And then we can look at depressed fractures, which those are locally broken in several places and is depressed. And that's typically going to require some sort of surgical intervention to remove the pieces of skull that are depressed. Acuminated is many linear fractures. This is can be very concerning. If the child was in a car accident, that's probably the cause of it. But if a child comes in reporting a fall, or the parents are reporting a fall, and we see many linear fractures, then that's a sign of child abuse. There's something else going on there. One fall probably isn't going to cause that. The basilar skull fracture is at the base of the skull, and it's going to involve a dura tear as well. With the open fracture, we're looking at a risk for a cerebral spinal fluid infection, because like it says, it's open. So we've opened up that space and have allowed the potential for infectious agents to go into the cerebral spinal fluid, which is full of stuff that bacteria just loves. So it rapidly multiplies once it's in there. And then a growing fracture is when we have a dura tear that doesn't heal, and that's considered a growing fracture. Usually it occurs before 3 years. So this is just a list of some of the complications of head trauma. And we can look here. You can see an epidural hematoma and a subdural hematoma, and you can see how they impact the brain and where we end up with a herniation of the brain, which is going to be pretty drastic if we have herniation. So any type of hemorrhage, we're going to need to intervene very quickly to mitigate the damage that occurs. So how are we going to evaluate a head trauma? So a child comes in and we are going to do what? We are going to take a very detailed history. And again, airway, breathing, circulation. So even if we suspect something horrible, we still need a breathing child. That child still needs to have oxygenated blood to live. So we're going to make sure we have that. We want to assess for shock, and then we're going to start in our neurological assessment. The vital signs, again, are going to be just unstable and a wide range. So we might see hypotension to hypertension, we might see tachycardia, bradycardia, tachypnea, and just the vital signs are going to be all over the place. And one key assessment with our neurological examination, remember, is those pupils. And then we're going to move on to the specialty tests. So we're going to potentially do a CT scan, an MRI, and just continue those behavioral assessments. So some of the things that can happen after a head injury are listed here. So we have our post-concussion syndrome. This is going to be nausea, dizziness, headache, photophobia, fatigue, irritability, and this can last from days to 6 months. We might see restlessness, a lack of focus, and memory loss. When we're looking at seizures, it's usually within 24 hours to 1 week that we see a decrease in neurological activity, or we see a neurological impact. When we have hydrocephalus, this is a structural complication, and it might be caused from a depression fracture, or we are going to have sorry about that. Where are we? So the structural complication. So hydrocephalus is an example of a structural complication that can occur. And with structural complications, we are just going to see the decompensation. And it's really going to depend on the nature and the location of the injury. And the manifestation can last from several days to months for any of these issues. So what are we going to do in the hospital? So in the hospital, we're going to be looking at their level of consciousness. So this is going to be assessed on an ongoing basis to determine where we are with the level of consciousness, which is going to help us determine the level of neurological insult. We're not going to give them anything orally because we aren't sure if the child's going to begin to vomit, and we don't want the child to aspirate. We're going to think about surgical therapy. So, for instance, with the depressed fracture, we're going to probably be going to surgery. The prognosis is wholly dependent upon the severity of the injury itself. It's more favorable for kids than adults with traumatic head trauma, and but it really just depends on the severity and the location. It can range anywhere from slight personality changes to complete brain death. Again, When we're looking at the assessment, we're going to assess frequently for vital signs, neurological changes, and level of consciousness. Level of consciousness is going to be one of the most important indicators for us. And it's really important that it's the same person assessing the level of consciousness as often as possible, because that person will notice small, minute changes that somebody else might not see, because they're the ones who are there and who have been doing this assessment. We're going to Everything we're going to do is going to be very careful, and we're going to want to record adequately what's happening with the child so that subsequent caretakers are able to have a good understanding of what's going on. We want to be honest, kind, and compassionate with the family. We don't want to sugarcoat things for them, but we also don't want to gloom and doom them. So we want to be upfront and honest with them, and allow them to, give them a shoulder to cry on if they need to have that, and provide them with the information, make sure all of their questions are answered, bring the doctor back if needed, and be as compassionate as possible with them. We're going to want to initiate rehabilitation as soon as possible. This is going to be important to help the child achieve their optimal outcome for rehabilitation. So we want, again, to make sure that we get that initiated as soon as the child is medically stable. Some of the best ways to avoid this is prevention. A big contributor to head injuries with infants is infant walkers, because the infant falls down the stairs and they're top heavy. Remember, those heads are the biggest part of them. So we want to educate parents and families that those infant walkers, they don't really teach the baby how to walk, and they can be very unsafe. So it's a good thing to educate to, not purchase. And don't buy it if it's on your family member's registry. Just avoid that one. We're going to look at some of the other causes of cognitive injuries, or so drowning or near drowning is a major cause of accidental death in children. So drowning can occur in just a small pail of water. It doesn't have to be a big pool. A couple years ago, we had a fall festival in our neighborhood, and there was I think it was one at the time, or maybe a little bit, I guess, almost two. And a little toddler toddling around, and we were bobbing for apples, and there were adults everywhere, and this little guy went and fell into the tub where people were bobbing for apples, and he went head in, and he could not get himself out. And it was not a big tub. It was probably, this high, because it was for kids, but he was in. And to watch that happen was incredibly scary, but it really put it into perspective that, yes, they are very top heavy. They're going to go in and they're going to stay in. They're not coordinated enough or strong enough to get themselves out. Drowning occurs most often in toddlers, in boys, and in African Americans. So the pathophysiology of drowning is obviously, it's a hypoxic event, so we are not going to, our brain is not going to have enough oxygen, right? So our brain can survive for about 4 to 6 minutes without oxygen, without any sort of dysfunction, whereas the heart and lungs can last 30 minutes. So you can see why there's drowning and near drowning, because the near drowning is going to end with significant cerebral dysfunction. However, the heart and lungs, it won't cause death. We will get pulmonary edema, atelectasis, and airway spasm with these near drownings, and the child is going to be probably in both respiratory and metabolic acidosis. So we want to provide oxygen as quickly as possible. We're going to start emergency resuscitative efforts as soon as possible. And then we're going to treat based on the degree of the insult. So we might see an aspiration pneumonia usually comes up between 48 and 72 hours after. And any child who requires any sort of resuscitation, we're going to hospitalize for observation. So the best predictor of how the kid is going to do is going to be the length of submersion. If it's less than 5 minutes, then the child is usually going to do pretty well. If it's more than 5 minutes, then there's usually some significant damage. We're going to put them in an oxygen-rich environment and observe for a minimum of 6 to 8 hours, because we can have complications in that time frame arise. So one of the things that we really need to look at with near drowning incidences and drowning incidences is our own feelings, because we're going to potentially look at this as neglect. So somebody wasn't watching the kid, right? And that's why they fell into the water, or they don't have the appropriate fence around their pool, or they put the baby in the bathtub and walked away. So we really need to explore our own feelings about this and have an understanding of how we're going to approach instances of drowning and near drowning. We're going to want to be able to provide resources and support for these family members. Moving on to intracranial infections. So the central nervous system as a whole has a limited response to injury. It doesn't have a lot that it can do. When we do end up having a injury or even an infection, we a lot of the times end up with acute febrile encephalopathy, which is going to it's going to cause inflammation in the brain. Bacterial meningitis is a really common cause of encephalopathy, and we actually have some fabulous vaccines to help prevent the transmission of HIB, which is the most common cause of bacterial meningitis. Bacterial meningitis, people describe as the worst headaches of their lives. People they can't really move their head, and it can come on very quickly, especially in children. So lumbar puncture is going to be our best diagnostic test to determine whether or not we are dealing with bacterial meningitis. If we are, we're going to put the child in isolation. We're going to start antimicrobial therapy immediately, and we're just going to maintain supportive with support of the child and what they need. So respiratory support or whatever they might need to ensure their quick recovery. So some of the things that we're going to treat with is we're going to utilize dexamethasone to decrease the risk of neurological problems. And then for antibiotics, we're going to use cephalosporins. I see an error on my slide here, but that's okay. So the prognosis is there's generally some soliloquy after bacterial meningitis, but it just depends on the promptness of the treatment and what the effects are before the treatment takes care of the problem. And I need my beverage. 1 second, sorry. So prevention is going to be key. So we're really going to want to try to prevent any problems that might occur with bacterial meningitis by preventing bacterial meningitis altogether. So these kids are really sensitive to stimuli. So we're going to want to keep the light down. We're going to want to keep the noise levels at a minimum, and we're not going to want to move them very much. The head of the bed we want elevated to, again, decrease the intracranial pressure. They might be more comfortable on a sideline position because they have nuchal rigidity. Their neck is just really rigid. And so we really want to monitor their pain as well and treat depending on what symptoms they're having. From a familial perspective, again, it's education and support. But these family members might feel guilty because they didn't suspect how serious this condition was initially. So we might just let them talk about that and help them to understand that there was no way for them to know necessarily that this was as serious of a condition that it was, or bring up what things to look out for next time. Use it as an education experience. For non-bacterial meningitis or ectopic meningitis, it's typically just short without any significant complication. You can see the potential causative agents here. So we're gonna support the patient. We're not really gonna be able to treat necessarily with antibiotics. So we're gonna just give them support and help treat their symptoms. Rabies. So rabies it's not very common, mostly because it has to be a bite by an infected animal. And typically it's from wild animals. So 91% of the bites occur from wild animals. One thing with rabies is that once the symptoms are present, it's too late. So a key nursing role related to rabies is ensuring that parents know if their child is bit by a wild animal or any animal for that matter, they need to bring their child in to receive treatment. It's typically, again, a wild animal. It's an unprovoked attack because this animal is neurologically going insane. So it's an unprovoked attack, but we want to treat every child who's been bitten by a wild animal or bitten in a non-provoked attack as if they do have, as if the animal did have rabies. We're going to give the rabies vaccine. We're going to give it on the day that it occurs. So at day 0, day 3, day 7, and day 14. We're going to use globulins at the wound site to hopefully prevent the systemic circulation of the rabies. We're going to clean the wound really well, and we're going to utilize the immunoglobulin as soon as possible. So another disorder that we look at is Rabies syndrome. And this is really it's a toxic encephalopathy. And we're going to assume Rabies syndrome if we have a fever, profoundly impaired consciousness, and liver involvement. The liver involvement is really what's the key aspect of the Rabies syndrome. Although the cause isn't well understood, it really correlates with viral illnesses like influenza and varicella, and the child having those illnesses and receiving aspirin has been shown to increase the incidence of Rabies syndrome. We're going to see cerebral edema and fatty changes in the liver. So from a diagnostic perspective, really a liver biopsy is going to give us the best information. And we're going to, in our labs, we're going to see an increase in peak ammonia concentration. We do have a pretty good prognosis though, and we're just going to want to monitor eyes and nose and lab values. Seizure disorder are the most common pediatric neurological disorder. So if you plan to practice in peds, this is probably something that you will come across and see. Seizure disorders vary widely, and we're going to look at a variety of different types. So epilepsy is considered if the child has 2 or more unprovoked seizures. So an unprovoked seizure is one that just comes on. It's not caused by a trauma. It's not caused by an electrolyte imbalance, but it's an unprovoked seizure. So we can have acute symptomatic seizures from head trauma, meningitis, all of the things listed here. And box 4.6 really expands upon a lot of these and gives you some great information. We're going to classify seizures on how they occur. We can have partial seizures, which is local and involves very little of the brain, or generalized seizures, which is going to involve both hemispheres of the brain. For the therapeutic management of seizures, we want to reduce the frequency of the seizure and the severity of the seizures. We want to know if there's a cause, and if there is a cause that we can identify, we're going to try to correct it. For drug therapy and for management as a whole, we're really looking at epilepsy, because if it's epilepsy, remember, is those seizures that don't have an identifiable cause. So if there's an identifiable cause, we're going to fix it if we can. Otherwise, we're going to manage the seizures, which is epilepsy. So we're going to look at drug therapy, and the drugs we're going to look at are drugs that raise the threshold of excitability. And the idea behind that is that the seizure won't occur because the brain is allowed to get as excited as it wants to, essentially. Another aspect of management is the ketogenic diet. In fact, the ketogenic diet is quite the fad diet right now, so many of you may have heard of it. However, it is a decreased, it's a diet that's very high in protein and it's high in fat and low in glucose. So essentially what happens is the body starts to process fat as its energy source instead of glucose. The vagus nerve stimulation is a stimulation of the vagus nerve. It requires a surgical placement of the stimulator, and it has pretty good outcomes. 1/3 to 1/2 show a reduction in the seizures after 1 year of therapy. Surgical therapy is if we can identify a cause, we're going to remove it. Status epilepticus, nope, not going to happen tonight, sorry, is a seizure that's lasting more than 30 minutes. So if that's going on, then we're going to call 911 and they're going to need to get to the hospital. One of the primary treatments for this is IV Ativan is what's going to be used. The other thing is that if a child experiences a seizure for the first time, we're also going to want to call 911 and have them go to the hospital, because we don't know what the cause of that seizure was. So we want them to have a full workup as close to when the seizure occurred as possible. So we will get them going to the hospital then. The prognosis of seizures is actually pretty good. Only half of children who experience one seizure experience another seizure. With long-term care, we're going to utilize the the management that we spoke about in the previous slide with various drug therapies and diet changes to decrease the number and the severity of those. We're going to talk to the patients and determine what the triggering factors are. Sometimes it can be a food, sometimes it can be an emotion, sometimes it can be a bright light. So we're going to want them to keep a journal and keep themselves aware of what's going on, and the parents are going to have to be involved in that to determine what the triggering factors are. And as with any disorder, the goal is for them to live as normal a life as possible. Febrile seizures can happen in young children, and you can see the statistics here. And how we identify something as a febrile seizure is that if the child has a fever and is seizing. Now with febrile seizures, it's interesting because antipyretics will not affect the actual seizure. So bringing the child's temperature down isn't going to stop the seizure once it occurs. So what's key here is making sure that the child's temperature doesn't get to the point that would initiate that seizure. So that's going to be how we prevent. And you can see it's twice as frequent in boys, which is kind of interesting. And with this one, we are going to want to call 911 if the seizure is lasting more than 5 minutes, because we want to make sure that we can stop it and help that child with any respiratory issues that they might be having or anything like that. So, which of the following is appropriate care for the child who is unconscious? Change the child's position infrequently to minimize the chance of increased intracranial pressure. Avoid using narcotics or sedatives to provide comfort and pain relief. Monitor fluid intake and output carefully to avoid fluid overload and cerebral edema. Give tepid sponge baths to reduce fever because antipyretics are contraindicated. What do you think? So this is a great NCLEX question because there seems to be lots of correct answers. However, we want to go with what's the best answer, which is going to be C. Monitor fluid intake and output carefully to avoid fluid overload and cerebral edema. Thank you.